Perfect. All right. Good afternoon. We're delighted to present our didactic contrast enhanced FASEDAM in adult and pediatric trauma approaching CT accuracy at the bedside. This didactic is sponsored by CEUS. So my name is Laura Oh. I'm an associate professor at Emory University. I'm joined by Erin Chen, who's the ultrasound director at CHOP, and Toby Kumar, who's the ultrasound director at Mayo. Toby is also vice chair of the POCUS community of AIUM. A few disclosures before we begin. So for disclosures, we have some grant funding. I'm funded by the Department of Defense, and Erin is funded by the Thrasher Foundation. And we also want to note that the use of contrast enhanced ultrasound in trauma applications is off-label. So our objectives today are to talk about intro to microbubbles, contrast enhanced ultrasound in adult blunt abdominal trauma, and then to talk about pediatric blunt abdominal trauma and contrast enhanced ultrasound. We want to talk to you about lessons learned from putting CEUS into practice, and then give you a demo of contrast enhanced FAST. We will also have time at the end for audience questions. So contrast enhanced ultrasound has a potential to revolutionize POCUS by expanding use into clinical applications previously reserved for CT, MRI, and angio. So what exactly is contrast enhanced ultrasound? It's a technique that enhances traditional ultrasound by the use of ultrasound contrast agents. And these ultrasound contrast agents are gas-filled microbubbles injected intravascularly or intravesicularly. Microbubbles are the size of a red blood cell or smaller, and therefore a true intraluminal agent. Unlike CT contrast, they do not leak from capillary membranes. When ultrasound beams hit microbubbles, three things happen. At very low acoustic power, the microbubble is just a passive reflector. At very high power, you see a destruction of microbubbles. At low power, with a mechanical index between 0.2 and 0.4, the microbubble passively reflects, but is also an active generator of sound energy. And so you see that at low mechanical index, the tissue and blood reflect predominantly at fundamental frequency, but with microbubbles at low mechanical index, they reflect at both fundamental and harmonic frequencies. And so your ultrasound machine can subtract the fundamental frequency and just focus on detailed images of tissue perfusion at the capillary level. To give you a brief contrast agent history, so in 1991, contrast agents were made of galactose shells that were air-filled. Our second generation agents, Optison, Definity, and Lumason, are hardier. The earlier agents only lasted about a minute in circulation. So these newer agents have serum albumin or phospholipid shells, and they contain inert gases and are stable in circulation for a few minutes. So these are metabolized by the liver, the gas is exhaled, and contrast is eliminated from the body in 1 to 15 minutes. Initially, the FDA put a black box warning on these ultrasound contrast agents because they were receiving reports of 11 deaths and 190 severe cardiopulmonary reactions that occurred between 2001 and 2007. Subsequent to this black box warning, there are a large number of studies with patients enrolled, over 1,000, evaluating their safety, and they found that there was really no increase in mortality from using these contrast agents. And these studies were designed both retrospectively and prospectively. So given this new information, the black box warning was considerably softened. And currently the only contraindication to getting these ultrasound contrast agents is a known hypersensitivity to them. So all contrast agents continue to maintain a warning of occurrence of serious cardiopulmonary reactions. So when you're giving these agents, you should have resuscitation equipment and trained personnel nearby. So the main safety risk is the CARPA reaction. And mild CARPA reactions consist of things like sneezing, tingling, urticaria, pruritus. And more severe CARPA reactions, you'll see things like angioedema, cyanosis, anaphylactic shock. Pictured here is our friend Lori Stoltz, who volunteered to be my contrast enhanced ultrasound model at a recent conference. So in agreeing to be our test subject, she joined an elite crew of researchers who experimented. So we have Marie Curie, we have Jonas Salk, we have Toby Kumar, who has used Lumason so many times on himself, it's actually in his EMR medication list. So the incidence of serious allergic and anaphylactic reaction after ultrasound contrast agent use is 0.009%, 0.004%. So very rare, and spontaneous resolution is a rule. These are the following approved applications, FDA approved applications for Optison, Definity, and Lumason. So you see that for Optison and Definity, primarily the FDA has approved echo. For Lumason, you see approvals for echo, liver lesions, and vesicoureal reflux in pediatric populations. And those are the components of the FAST exam of sorts. We want to emphasize that as a panel, we have no commercial bias. All three of these ultrasound contrast agents will give you great images, but we have found that Lumason seems to be more appropriate for our work because Lumason is hand mixed at bedside rather than using a shaker like Definity, and it's stable at room temperature, which makes it unique among the three. And it's also FDA approved for both pediatric populations and for intra-abdominal applications. So recently I was awarded funding from the DoD for my BFAST study, Bubble Enhanced FAST exam. And so with this project, I'm looking at hemodynamically stable blunt abdominal trauma. And although there have been studies in Europe with contrast enhanced ultrasound agents and blunt abdominal trauma, they've mostly been in radiology suites, and this one is at the point of care. So we're comparing traditional FAST to BFAST. So in traditional FAST, we see indirect evidence of intra-abdominal injury by looking for free fluid, primarily in these potential spaces of accumulation, such as Bornstedt's pouch. For the BFAST exam, we're looking for direct evidence of intra-abdominal injury. We're looking at organs, specifically looking for laceration or extravasation. So I want to show you a few case clips. The first one is a liver laceration in a 64-year-old that was kicked by a horse. So we're doing a split screen, and on the right side, we see B mode ultrasound. And the laceration is very hard to see. Simultaneously, we're scanning and seeing with contrast what seems like a crack coming down the liver, and that is a laceration. So much more easily visible. Here's another example of a liver laceration case in a different patient. So again, we're showing you side by side what these images would look like, one in B mode and one using contrast enhanced ultrasound. There are subtle changes that you might see on the right side, but they're pretty hard to pick up. You may see a little bit of heterogeneity, but on the left side, that hole is very clear that there is a laceration there, right here. And finally, we have an example of a splenic laceration in a 28-year-old in a motocross accident. On the right side, in B mode, the near field is quite dark and it's hard to appreciate a splenic laceration. On the left side, there is a pretty clear laceration right there that even a fairly novice user could pick up. So there are many advantages of CEUS. It's cost effective. These vials are costing approximately $94 to $150, which is not that much in the grand context of how much trauma care costs. You can repeat the exam, it's portable, no sedation is required. And ultrasound contrast is not nephrotoxic. It's okay to use in renal failure patients. There's no need to check creatinine before performing the exam. Ultrasound contrast has a better safety profile than CT contrast and even Tylenol. And so as promised, we want to show you that contrast enhanced ultrasound approaches CT accuracy at the bedside for blunt abdominal trauma, at least so far in the hands of radiologists. So there have been many studies, mostly in Europe, which show an amazing sensitivity and specificity for contrast enhanced ultrasound. So in this 2009 Catalano study of 156 patients with 26 renal, 38 liver, and 43 spleen abnormalities, CEUS had 94% sensitivity compared to standard FAST exam with 79% sensitivity. And the specificity was 89% versus 92% using traditional ultrasound. Valentino, also in 2009, studied 133 hemodynamically blunt abdominal trauma patients and picked up 48 splenic lacerations, 21 hepatic lesions, 13 renal-adrenal issues, and 2 pancreatic lesions. And the sensitivity by the radiologist was shown to be 96.4% for contrast-enhanced ultrasound versus 70.2% for traditional ultrasound. CT itself probably is only 97 to 99% sensitive injury. So we're very, very close to what CT is capable of. So is that enough? Is 96% good enough? Unfortunately, ER docs and trauma physicians are addicted to CT scans, and contrast-enhanced ultrasound does not replace gold standard CT because it does not pick up injury to adrenals, ureal injuries, renal collecting system issues, bowel issues, diaphragm, or bony injuries to the pelvis, etc. So,
wait,
all the weed gummies.
oh yeah.
I do feel so much better, but my body needs.
Laura,
Laura, I don't think we can hear you.
you're
there we
muted.
go.
I think somebody muted all.
You're muted again, Laura. Still muted.
Okay.
Perfect.
All right. So, all right, everyone's okay? All right, cool. So we were talking about how use of BFAST requires a significant culture change that may not be there. And this was something that was noted by our EMF grant reviewers when we first applied for a grant in 2018, that there was a big culture change that needed to happen with trauma. So in the subsequent 3 years, we tried to repackage our grant, and we try to think of areas where BFAST might have a home. So we thought that we would apply for military funding, and we highlighted situations where a soldier might be acutely injured and not be able to get that CT scan due to danger and costs. So our grant proposal to the military was that this was an important triage tool in the field and could be used at point of care for. So other opportunities for contrast-enhanced ultrasound and trauma include low intermediate energy motor vehicle crashes. So all the people that are in the hallways, which are unlikely to have significant injury, ground level fall with unilateral flank pain, renal failure patients, patients with ascites, patients who you don't want to get a huge radiation dose, like pregnant patients, pediatric patients, may have a role in mass casualty events and in international settings where CT is a limited resource. So contrast-enhanced ultrasound, although it may not be a replacement for gold standard CT, becomes an important tool in the evaluation of trauma as a possibility. So I want to thank you so much. You've been a wonderful audience. And I'm delighted to hand the mic to the distinguished Erin Chen, who is also going to talk about contrast-enhanced ultrasound, but in the pediatric population.
Great, thanks, Laura. As Laura mentioned, my name is Erin Chen. I'm the director of the Emergency Ultrasound Program at the Children's Hospital of Philadelphia. And I'm going to be talking next about the FAST in children, pediatric patient population, and some of the controversies that might lead to why we would consider using contrast-enhanced ultrasound for the FAST exam. So as many of you probably are aware, the FAST exam is now, like, it's very well set in the adult literature. It's part of ATLS, but in pediatrics, it's actually fairly controversial. There, as a screening exam, you're looking for free fluid, and so there's some problems with operator variability, but also one of the problems is that children are often running around with fluid in their belly just normally, either from like a recent gastro or for whatever. And conversely, patients in the pediatric population for whatever reason can have significant injuries, including significant liver lacerations and splenic lacerations without detectable free fluid, even on CT or potentially even MRI. One of the other issues is that in kids, as opposed to adults, most of these kids, even with significant intra-abdominal injuries, are managed non-operatively. And this is, I think, a change that's happened over the last 10 to 20 years. And so for all these reasons, we actually don't use FAST very routinely at our institution. I can think of maybe like a handful of times where I've actually used it clinically. This leads to why we consider using contrast-enhanced ultrasound. So, kids especially are, we think are more sensitive to radiation risk. And this is one thing we often struggle, in kids like that come in that look well, is this someone that we want to do potentially a CT scan on? And we're much more cognizant of this, I think, potentially than in adults. And then the other issue is that because kids are managed, even though kids are managed non-operatively, we actually do still want to know about these injuries. For example, one of the kids in the study that we're doing right now was actually a kid who was struck by a lacrosse ball and had some belly pain, went to an outside hospital ER. And I can only imagine what they were going through, thinking, this is a kid I should image. They ended up doing an x-ray, diagnosed the kid with constipation and sent him home. And he continued playing lacrosse, soccer, whatever it was, and actually collapsed on the field and was taken back to the hospital a few days later and had a pretty significant splenic injury with a hemoglobin of 7. And so again, I think there are implications for knowing about these injuries. A lot of people say, in a stable patient, do we really care? But I think there are implications for when can they return to school? When can they return to sports? And again, many of these kids are often watched in the hospital for at least a few days. This was an example of a kid that we saw at our institution many years ago. It was an 11-year-old autoped who had a pretty significant injury, but looked well, was cleared off the backboard, had a FAST scan done that was negative. Because of persistence of abdominal pain and tenderness and an increase in LFTs, he ended up getting a CT scan. And you can see here, he had a pretty significant grade 4 liver laceration that you can see here on the right. And so many of you are probably familiar with this study that came out in JAMA a few years back. It was a single center study, but it was a randomized controlled trial looking at close to 1,000 kids with stable blunt abdominal trauma. And they compared them to, they compared standard trauma valve versus a FAST plus trauma valve, and basically found no significant difference in rates of CT usage, ED length of stay, hospital charges, et cetera. Another study here was actually a multi-center study of 14 level 1 pediatric trauma centers where they looked at kids who received FAST versus not. And what they found was that the sensitivity in this particular group, the sensitivity is around 28% for the FAST exam. And the specificity was decent at 91%. But again, I think their conclusions were based on this, that, that the FAST exam is probably not beneficial in routine use for pediatric patients. One other interesting finding in this study is that we usually say that the best use of FAST exam in pediatrics might be for that patient that's hypotensive in your trauma bay, who you're trying to figure out, what's the reason for their hypotension. And in this particular study, they actually found that the accuracy of the FAST exam was actually fairly low, around 61%, surprisingly. And again, so I think it calls that into question as well. And again, there's a lot of literature that kind of, I think, is a little bit all over the place, and some of it is, again, depending, varies by institution and probably operator characteristics. But again, I think the overall gestalt, I think, is that it's a little controversial in kids. This was a case that we saw also in our institution early on that I think highlights some of this. Is a 3-year-old who presented with altered mental status to our trauma bay, was actually taken directly into our trauma bay because of how ill they were. They were hypertensive and tachycardic. There was an ISTAT in the trauma bay that was done that showed a hemoglobin of 4 and a FAST scan that was positive. And I think, in adults, this would probably be a kid that, we would use this FAST scan as a triage tool to say, this is the kid that should go to the OR. But this kid, for multiple reasons, ended up just going to CT that confirmed a large liver laceration from suspected non-accidental trauma, and then was admitted to the PICU and managed non-operatively with like fluids and just and blood replacement. This was another study about a group out of Wisconsin that looked at a national database and looked at trends over the early 2000s, so 2000 to 2009, and they, in essence, just found that the significance of the rates of operative intervention for kids dropped pretty significantly by almost half from the early part of the study to the later part. And again, just showing, I think, I would say even nowadays, it's even probably more than that, it's very uncommon that I hear of a kid that actually goes to the OR, even with significant injuries. And so all of this, I think, leading us to, can we do better with a FAST exam? And I think this is where contrast ultrasound has a real potential to be beneficial, and maybe either as a screening tool or potentially even as a direct replacement tools for CT scan. So you can actually look at injuries to the organ. We're not looking for free fluid as a marker. We're actually looking at the organs themselves, as Laura mentioned. So this is our study that was funded by a generous grant from the Thrasher Research Foundation. We're trying to enroll about 150 children with hemodynamically stable blunt abdominal trauma who have received or are planning to get a CT scan. And then we do the CEUS or contrast exam within 72 hours of the CT. Our primary aim is to determine the test characteristics of CEUS for the detection of intra-abdominal organ injury to the liver, spleen, pancreas, and kidneys as compared to the gold standard CT. And then one of our secondary aims actually is to see if we can do this as a POCUS exam by PEM physicians. Currently, and also to determine the safety and tolerability profile. I think this is actually well established, but again, just the more data we have, especially in kids, the better. So we are about 3 years into the study, and we've enrolled about half of these kids, and we're hoping to do the POCUS part of this exam relatively soon. All right, this is I'm just going to show a few examples of some injuries. This is a 7-year-old who presented 3 days after a fall. This is the liver. So you can see that we usually have a grayscale image on the right compared to the contrast exam on the left. And as the contrast bubbles are going in, you can see that there is this area of hypoperfusion right here down the middle. It's hard to see on here on the grayscale image on the right. And then this is what we call an early arterial phase. And then you can see even a little better, I think, during the kind of late venous phases. Right here, that same patient. The next patient is a 10-year-old who tripped over a log. So a seemingly benign mechanism of injury, but she had left upper quadrant pain. And here we're looking at the spleen. Again, the contrast image on the right and the grayscale image here on the left now. And as the bubbles are, as the contrast agent is being injected, you can see the bubbles filling the spleen, and then wherever there's an area of injury that's being hypoperfused. Again, you can actually see it here on the grayscale image. It's I think it's just much more easily seen and much clearer to see here on the contrast exam. This is an 8-year-old who fell from a hammock with a renal injury. Again, here's the spleen and then the kidney. As we're injecting, you can see the spleen enhancing, the kidney enhancing, and then there's an area here that you can see that's being underperfused. And then during the later phase, it's much easier to see again. You can see it extends all the way to the cortex, actually, here. And this was actually a very recent case, was a 17-year-old who had a rollover MVC. And you can see has actually a positive FAST. You can see this area of fluid here. This is the liver and the kidney. And as we inject, you can see the right kidney is enhancing nicely. The liver is enhancing nicely. And then if you look closely, there's actually little bubbles of air that are actually going into this area in Morrison's pouch. So this is an active adrenal hemorrhage that you can actually see. So, so not only can you actually look at organ injury to the liver, kidney. So we look at the liver, the 2 kidneys, the spleen. We look at the pancreas and the adrenals. You can also look for active extravasation. some of the things, obviously there, as Laura mentioned earlier, this is probably most useful for those with stable blunt trauma, and especially those with polytrauma or significant mechanisms. You might still want to do a CT scan because obviously you get more of a global look, and the contrast exam obviously is not looking at other things like fractures. Although you can look at the bowel, it's difficult even on CT scan, and probably same with contrast. And then because this is not excreted by the kidney, you're not going to be able to see as well ureteral injuries. And then I would say that there's also some limitations by patient cooperation, or body habitus. So again, in your very obese child, you may have some trouble getting good images, or those with significant tenderness or abrasions potentially might be limited. And so you might still need to do a CT for that. But again, I think, again, this is for those kids where we really struggle in the ED, like whether this is a kid that we want to do a CT. I think, if I had an exam like this, I think we would very easily do it. And even though most of those kids do fine, even with injuries, again, it's something I think you do want to know about and can give some better guidance for like return to sports recommendations, et cetera. And then I think there will be some more work that will be done, like can this help triage and look for active extravasation for those that might need more urgent intervention. And that's all I have. I'll just say that if you're interested in learning more, we were doing the radiology department at our institution was doing a monthly course on contrast ultrasound. Right now it's on hold because of COVID. I think there's a virtual session planned in September, and then I think with plans to resume once the restrictions are lifted. But feel free to reach out if you're interested, and I can put you in touch with the people that hold this course.
Perfect, thank you. So let me share. Oh yeah, we have to start. Let's take this over. And we I think I might have to share desktop. Let me just make sure I have it open. We just had it open, didn't we? 1 second. Interestingly, it closed and didn't show up as share anymore. I had this before, and that must be my Mac. Here we go. Sorry about that. So I'm going to just talk about a little bit about the practical applications, and I'm going to talk about the exam and give a demo. Initially, we had planned to do a live demo, but that turned out to be pretty difficult just with the Juno and the Zoom platforms to get multiple video streams. So let's talk a little bit about how we can, what the exam is kind of more practically and how to put it into place. So the contrast exam, you need a couple of things. You need the contrast agent, and we talked a little bit about this. You need to have certain machine requirements that your machines have to support. You have to select the right transducer, and then you have to have IV access. And we talked about the safety, so I took that out because it was already addressed. So the contrast agent, just very briefly, there's 3 commercial contrast agents on the market. They all work well, and some people have stronger feelings about one on the other in terms of visibility, but they all work pretty well. It comes down to which one we use is, like Laura said, has to do with the storage and activation and the FDA indication. So if you look at the 3 things, Definity, needs to be refrigerated, activated in a vial mix. Lumison can be in room temperature and hand agitated. And then Optizon is refrigerated, but then you can just roll it in your hand and it's ready in a few seconds. The other consideration is basically if you want to start a program or kind of start using it, I would look what you already have, because under guarantee your cardiology team already has one of these in the hospital formulary, and sometimes it's difficult to get things on formulary, and usually to partner with kind of the higher use departments, mainly cardiologists, to get it there will help you. And in our case, they used to have Definity. They were really interested in trying Lumison, so they helped to get into formulary, and that was much smoother than if we just had to try to on our own with that. Also, if you kind of start a program, you need to get everybody involved, and if you want to use it clinically, you have to, we always say, just be transparent what you're doing. There's several committees you probably have to approach. For us, I think it was 6 or 7. There is, a group that is very supportive in our institution, the pediatric surgeons, because of the problems, the high threshold that they have for CT scanning. And so there's actually a lot of interest, and even within the radiology group, there's more and more interest in this. A little bit about billing and reimbursement. The question came up before. So currently, I don't think anybody who would bill for specifically for a contrast exam has tried. We're looking into it right now. So there is a CPT code specifically for the liver. It's to look at initial lesions. It's meant for like solid liver lesions that radiology looks for, like hemangiomas and cancer and things like that. Theoretically, it could be extended to trauma as well. That would be for the liver. There is an additional HCPCS code that gets added to it. There was for 2 years, there was a fast track billing method to get additional reimbursement for the contrast agent that you would add, but that expired in September 2020. There's some discussion about having a more robust billing scheme or billing setup for contrast enhanced ultrasound, but these are your two CPT codes, or your CPT code plus the HCPCS code that you theoretically could try to bill under. So you would bill a standard fast exam, and then to assess for liver lesion, you would bill the other one. But I don't know anybody who has successfully done that in trauma so far. But there is potentially a way. So what about your ultrasound machine that you have? What you need is, not every machine can do it. You need a specialized contrast package that can do this lower energy imaging, low MI imaging. It needs to have some very specific contrast imaging techniques. And also quality matters. There are differences in quality. The scans on the left side, we kind of have a lower end machine, on the right side a high end machine. As you can see, that things like the bubble resolution and things like that, and the refresh rate is much higher if you use a higher end machine. So we're not really sure how that impacts, the kind of overall sensitivity, but there is a difference in that. So it's really worth looking at the different contrast agents. This is just a selection. I have no vested interest in any of them. But these are point of care machines that can do contrast. Point of care machines I define as a machine that can scan on battery, because a lot of the larger systems that can't scan on battery, which is not going to work for us. But this is a good selection. There's probably more out there, and I apologize to anybody who has a product that I didn't mention, but just look at your favorite manufacturer, talk to them, and they would probably be able to give you a demo. But this is just a selection of machines that support contrast imaging at the bedside. What about transducers? So typically, there's a whole range of transducers. They all have to be able to scan at a fairly low frequency, which has to do with the resonance frequency of the bubble, which is about 3 to 5 megahertz or less than 5. So all of these you would scan on a very low frequency, but potentially you can scan from a phased array, curvilinear array to linear array. Obviously for fast, most people would do the curvilinear array. As I said, you have these specific imaging techniques. Typically, the machine has a button for a timer, which is helpful to kind of estimate how much contrast you have left. Usually, good imaging time is 3 minutes. You still have bubbles at 5 minutes, but then kind of it goes down in terms of detecting injuries. And then they have a button for what's called a high MI burst. Sometimes that helps. When you push that button, it will increase the MI briefly for a second and then destroy all the bubbles. This is what it looks like. So you push the button and then it gets reperfused in that one plane that you're scanning right now. So ID access, you need that. Obviously, the bubbles need to go in. The traditional method is that the contrast should be in line. So it should be in line with the IV, because you don't want to force them around the corner. Any pressure changes or high pressure situations can to potentially destroy the bubble. So you would give a contrast bolus and then you flush it with normal saline. I can tell you that we have had situations where we used it without the flush, because it takes some maneuvering and traumas with a 3-way stopcock. It does work. The flush usually gives the contrast a little bit extra boost. Also, for who's interested, we're publishing this right now. We have used it through an IO, and it does work through an IO. What you don't want to use, and Laura can attest to that, the clave connector will destroy your bubbles. So you should not use that. So I had that happen once to me where I had no idea what happened, and Laura had that happen as well. So you probably need to go directly to the IV. So what happens, this is what contrast looks like when it's mixed up. It's nice, milky. If you put a lot of pressure in your hand, then it turns clear because all the bubbles get destroyed. Our protocol, there's different ways to do this, and remember, this is a scientific assembly. We want to give people ideas, what's out there and what should be researched. And this talk shouldn't be said as, oh, this is a ready to use, like fully studied application. We want to give people ideas to carry this further and then, help us get some evidence that we need for more routine clinical practice. But this is what we use, and there's different ways to do it, but this is what we do. We do 2 injections. We give half of the Lumison with 2.4 mL with a flush. Then we look at the right kidney, liver, and then we look for contrast extravasation if there's positive fast. And then we do a second injection on the other side, again 2.4 mL, and then we look at left kidney, spleen, contrast extravasation. We do look at the pancreas at the end, but Aaron pointed out yesterday when we talked about it that actually the pancreas enhances early when you give the contrast. So if you want to look at the pancreas, you might need to move that up more right after the contrast injection. This is for the adults. For the pediatrics, we have the manufacturer says you should use 0.03 mL per kilogram. We just because in trauma it's a little more complicated, just to do all the calculations. We broke it up into 4 different categories: less than 10, 10 to 20, 20 to 40, and then above 40 they get the adult dose. Same thing. I'm going to just to repeat that. This is 2 injections. There is such a thing as too much contrast. If you give too much, like the whole dose, 4.8 mL in one time, you're going to have too much contrast and actually going to have difficulty scanning. If somebody's interested in, this is a very good English book in English by one of the experts actually from my home country in Germany. It's fairly short, but it really describes how to use it. And I always recommend this book if somebody's interested in that. So let's talk a little about the demo. The first one is how to mix it. So again, I have no vested interest in Bracco. It's just that what we use for the reasons I told you before. So what you do is you get it in this package. And when you open it up, you have a couple of things in there. You have the vial with the contrast with the powder. Then you have a saline syringe that has a plunger at the end. And then you have a spike. So what you do is you open your the vial. And for us, we trained our pharmacists when they're available, or the ED nurses can do it as well. Then you open it up, you put the spike in there. For physicians, we don't do that very often, mix medications, but that's why it's always nice to get nursing involved early, because they're much better at more used to kind of preparing medication. Then you insert the plunger. There's a little plastic ring at the end. Don't remove that because it prevents you from pulling out the plunger. So just keep the plastic ring at the end. Then you take the cap off, and then you inject the saline into the vial with the contrast with the powder, and then you activate it, and you activate it by shaking it. You have to shake it for 20 seconds like this, and then it's done. Then you have a milky white solution that you can then pull back into the syringe, and then you're ready to go. The little cap that's on there, we just put it back on so that it's just kind of protected. It's good for several hours, up to 3 hours once it's activated. It might sediment when it does that, then you just either hand roll or shake it a couple of times. So, and then you have 4.8 mL of the contrast afterwards. So the next thing, what does an exam look like? And I apologize a little bit for the exam. Initially, I said we wanted to do it live, but then we decided to do a recording. Because of the HDMI output of the machine, plus we had a brand new contrast package that actually we're still trying to figure out how to get to all old settings. It looks a little bit washed out, the contrast phase. So what we do when we do this exam, go back one. It was too many things. Let me just go and I think the video is just so big that it's a little bit hard to go back. Let me just go back here and share again. So when we do this, so what we do, obviously, in the beginning, we do a standard fast exam. Down on the right side, you have the kind of our exam, then the screen is there. So we do a standard fast exam, and I kind of would like to see actually how well the organs, we think that we'd be able to visualize the organs, especially in adults. It might not be worth given contrast if you really have poor visualization of the organs. You still could look for active extravasation in a positive fast, but ideally, and that's why it's the images are usually so much better in pediatrics, you want to kind of be able to investigate the whole organ, because if you don't look, you're not going to see anything. So we do obviously the right upper quadrant, the left upper quadrant, and then we do the pelvic view. I mean, everybody hopefully knows how to do a standard fast exam, but like I said, we kind of pay a little bit of attention to how well we can see the organs with that. And then we do the contrast part, and on the right side you have the reference image, on the left side you have the contrast image, and then we give the first injections, and there's the doses, and up here is a timer, as you can say. We start that to kind of give us a sense, in the trauma room, it's usually you kind of lose track of time, how much time you have, and so you start the timer. And then about after 15 to 20 seconds, the kidney gets perfused. So we look at the kidney first. And here's kind of where it looks a little bit washed out, what I said earlier. It's usually not as dramatic. You should see still kind of single bubbles. And then we, in a sagittal plane, we fan anterior and posterior. And always in any of these views, you want to look for active extravasations. Are there any bubbles outside of the organ swimming in the free fluid, which hypothetically would mean maybe the patient is at higher risk to deteriorate if they're still bleeding. So once we're done with the kidney, we do it in 2 planes. Then we move up to the liver, and we start off in a coronal view, coronal plane, as much as you can get, and then you fan anterior and posterior to try to get through the ribs as much of the organ as you can. And because the liver is a fairly large organ, you kind of focus and try to see if there's any injury. Then we actually get a couple of other views of the liver. After we have the coronal plane, we move up to a sagittal plane. And then you either slide over the left lobe of the liver and the right lobe, or you just fan left and right. But your goal is to try to see as much of the liver as you can. With that, and again, if there's any free fluid, you look for active extravasation. This is the gallbladder in between there, so there's nothing that you need to worry about. And then the last thing for the liver, what we do after the sagittal plane, then we do kind of a transverse plane, like a subcostal transverse, and then you fan up and down, and then now we have the liver in multiple angles to try to see as much as we can of the liver parenchyma with that. And this, we're at 2 minutes right now. After injection, then we would move over to the other side and do the second injection. Sometimes, depends on how big the patient is, sometimes you still have a lot of contrast left over from the first injection, and you can start investigating the left kidney. Sometimes, typically, this would be the point where we would give the second injections, because most people don't have that much contrast. But here in this case, it's actually me. I guess I have a slow metabolism, but there's actually a lot of contrast still. So if you look at the kidney, it still looks pretty well perfused, but for this demo, we decided to give a little more contrast because we are almost at 3 minutes then, and then we just give this same dose again that we did before. And then again, we investigate the kidney in the same plane, kind of initially sagittal, and then fanning up and down from there. So here you'll kind of notice right now it starts to fade out with the contrast, and now you'll see it kind of it will significantly increase again. The brightness of the bubbles will come in again, and you can kind of see look again at any lacerations with that. And sometimes, as I said, especially when we are in kids and the kid is kind of at the lower weight, but is in a higher contrast group that gets a little bit more contrast. Sometimes it's worth waiting a little bit until the contrast fades if you have too much contrast. And then we would move to the spleen, and you try to get as much of the spleen as you can. And then you, again, if there's free fluid around it, you would look for active extravasation with that. And I think the last thing I did here was just to demonstrate the flash button. There is a flash button. that when you push that, all the bubbles get destroyed. If you have a machine that has a focal zone, you want to set the focal zone at the bottom of the image. And typically you can tell if you have too much contrast, there's the flash, because then the bottom part of the image gets obscured because there's so much absorption from the contrast. And that was the exam. And thank you so much. That was my part. Let me stop sharing.
All right, so it looks like we only have 5 minutes, and there have been some questions that have come in from the chat that we were trying to answer as we were going along. And if you have any more questions in the last 5 minutes or so, we're happy to answer them. But I think the questions in their chat were things like, is there a CPT code for this? And I think Toby answered that in his presentation. That there is, that people are getting reimbursed for other applications outside of trauma. So you'll see cardiologists and echo, liver lesions and cancer patients, but I don't know of anyone currently who's billing for trauma application, although it could be possible.
Yeah, no, we going to look into it, but yeah, we haven't yet for that. Yeah, somebody said any adverse effects with IV infiltration. Aaron said he hasn't seen it. I haven't seen it. I also don't. There's one case where I thought it was maybe infiltrated, but yeah, it shouldn't. I don't think I've ever seen any reports on any local effects with that, because it is a gas, and at the end, the lipids are so minimal, and it's a gas, and it's taken up. Like if you would accidentally introduce some air subcutaneously or something like that, it's an inert gas.
And then Antonio is asking if, with this contrast and enhanced fast exam, could you also see free fluid?
Yeah, so you would do, you can see actually very well, especially between the organs, because the organs get very well delineated, as you saw in some of the clips, like Aaron has some clips of when there's free fluid, and you can see really crisp the organ and then the fluid in between. The reference image that you have is pretty degraded, because if you would scan at a normal resolution for your reference image, then it would destroy the bubbles. So that's why we typically just do the standard fast exam first to look for free fluid and get kind of an idea of what the situation is. I think the resolution goes down enough that probably I wouldn't rely on just the contrast view to assess for fluid, because the resolution is degraded.
Right. So the grayscale image that we have initially when we're doing the initial fast is not totally equivalent, because of the machine settings, to the split screen grayscale fast exam. So, all right, I think we are almost at time. If anyone has like one last burning question, I think you can squeeze it in, but otherwise, you've been a fantastic audience, and we appreciate your support in coming out and seeing this presentation. If you have any questions, please feel free to contact any of us. We'd be more than happy to help you with your projects. All right.
Thanks. Thank you.
Thank you, everyone.